Our next speaker is Kitae Chang, a second-year student at Robert Wood Johnson Medical School with a deep interest in the opioid epidemic. This academic year, he co-organized the medical students' inaugural Naloxone training in the class of 2021. He also co-designed the presently active non-credit elective called Introduction to Opioids, Addiction, Treatment, and Harm Reduction. Prior to his medical education, he worked for a few years in Port-au-Prince, Haiti for TK Haiti, a medical nonprofit that provides medical care to underserved populations afflicted with tuberculosis and HIV/AIDS. He spends his free time thinking of things that can be improved, writing and tweeting. His Twitter handle is Ty Chang, if you'd like to tweet him. With other students and physicians about compelling topics in medicine. Please help me welcome Ty.
I'd like to start off with a map. Now, I'm sure some people here might recognize this map. I'm sure some of the more dapper history buffs might even know who made this map. Well, let me help you out. This is an aerial view of Soho, London in the year 1854. As for who made this map, well, that would be none other than Jon Snow. Of course, not this Jon Snow. We all know he knew nothing. The Jon Snow I speak of is actually the dapper gentleman to his right, esteemed English physician, Dr. Jon Snow, who many in our generation consider the father of epidemiology. Now, suffice it to say that he knew more than nothing. In fact, he knew quite a lot. Around the time when that map was being drawn, London was being plagued by its second vicious cholera epidemic. Given physicians' limited knowledge about the pathogen at the time, patients who fell ill invariably died. Perturbed by this overt failure of medicine, Dr. Jon Snow stepped into the scene and helped to unravel the cholera mystery. Whereas most physicians at the time subscribed to what was called the miasma model of disease transmission, which is the idea that pathologies such as cholera were derived from the bad air, so to speak, Dr. Jon Snow actually made the bold claim that, in fact, the cholera was in the water. And how did he come to this conclusion? Well, it wasn't by spending countless numbers of hours in the laboratory performing experiments, nor was it by spending several hours in the library, poring over mountains of textbooks to synthesize a new theory of disease transmission. Instead, he simply used a map, the map I previously showed. By plotting all of the households that were infected by cholera, along with all of the public water pumps, which are shown in red and blue, respectively, an interesting pattern emerged. There seemed to be a connection between the location of the cholera cases and the public water source. Specifically, there was one pump in particular, the one located on Broad Street, that seemed to be at the epicenter of an ill population. Just as Dr. Snow had suspected, in fact, cholera had been swimming in the water all along. Now, there were unforeseeable benefits of seeing things from a different vantage point. For one, by seeing things on a map, we could come to better understand the way the disease was transmitted through the contaminated water. And number two, by seeing things on a map, we could propose a novel solution to a problem that had persisted for a long time. In this case, it was to get rid of that contaminated water pump. And as rarely occurs in medicine, a simple solution was found, and the cholera epidemic came to be no more. Of course, all of this took place in the mid-19th century. Surely we couldn't find this sort of utility of a map with a modern-day epidemic. Or could we? I believe we can. And the epidemic of choice, the opioid epidemic. Now, I'm sure most everybody here is well aware that America is engulfed in an opioid crisis. Since 1999 to 2016, the number of overdose deaths that has occurred in this country has nearly quadrupled. This is roughly equivalent to 2 times the number of deaths caused by the HIV epidemic at its peak, and roughly 2 times the number of deaths caused by motor vehicle accidents every year. Now, given that most everybody here is part of the medical school community, let me reframe that. Every day, we lose 175 lives to the opioid epidemic. Now, not long from now, about that number of students will be walking the hallowed halls of this hospital and our school, waiting to receive their medical school diploma. So let that sink in for a moment. And what about in our beloved state of New Jersey? It was last reported in 2015 that the death rate due to heroin overdoses was 3 times that of the national average. In the following year, in 2016, a state health report came out that stated if the second half of 2016 kept on pace with the first half, we should expect to see over 2,000 overdose deaths, approximately 1,200 of those due to a heroin and 700 of those due to a drug called fentanyl. Now, I'm sure all of you are wondering how all of this might look like on a map. Okay, you're probably not wondering that, but I didn't have a good transition, so this will let me transition into this map. So what we're looking at here is an aerial view of New Jersey in the year 2016. Each of the red points, as you might have guessed, represents a life that was taken by the opioid crisis on our soil that year. You know, this is a pretty scary depiction. And every time I look at this, I can't help but wonder how Dr. John Snow would have responded should he have seen this map. Perhaps with anger, or perhaps with fear, or perhaps with the biggest cop-out response of all time. Now, what's clear from this depiction is that the current opioid crisis is both rampant as it is widespread. As was the case for London's cholera epidemic, there are really no patterns here to denote at-risk populations. And that's because there are several risk factors for opioid use. Now, while it's of great interest to delve into the various etiologies of opioid use, to do so fairly would require an extensive, exhaustive review of key events in America's history. Events such as President Nixon's declaration of war on drugs, and even the Joint Commission's pain management standards rollout that led to the idea of pain being recognized as the 5th vital sign. For the purpose of this talk, allow me to succinctly summarize by saying that the driving forces behind the current opioid crisis are found in multiple realms, namely the biological, psychological, and social. And this is what explains the ubiquitous nature of America's opioid use. Nearly everyone, including everybody here, is vulnerable to opioid use. And from this, we should take away that there won't be a single point from which to address this problem. But how is the current crisis being addressed? And while many valiant solutions have been proposed, ranging from preventative options such as educational campaigns, to even policies to restrict opioid prescribing in medical settings, to even treatment options, offering medication-assisted therapies to individuals suffering from opioid dependence, there actually exists only one solution that acts to prevent an opioid overdose death, and that's Naloxone. Naloxone is an FDA-approved drug that acts to reverse an opioid overdose. It is incredibly effective given its quick onset, and it's extremely safe, given that it has virtually no side effects. In fact, if used on somebody who is not currently overdosing, like myself, it will have virtually no side effects. Observe. Case in point. I'm just kidding. This is why I'm not in drama school. But so Naloxone is available in an intranasal spray, which I think I've demonstrated, and it's very easy to use, just requiring a single spray into each nostril. Therefore, it's of no surprise then, in the last couple of years, several state governors have stepped forward to enhance access to this life-saving antidote. In 2013, for instance, Governor Christie of New Jersey passed what was known as the Overdose Prevention Act, which was a piece of legislation that still today enables healthcare professionals to provide this drug to individuals who may be at risk for an overdose, or may even be in the presence of others at risk for an overdose. Now, whereas most medical practices require a license to be practiced, administration of naloxone by the layperson is not only permitted, but it's protected by what's known as the Good Samaritan Clause of the Overdose Prevention Act. So all of this sounds great, right? So let's get out there and let's get some naloxone. At least that's where I started back in August of 2017. So I picked up my phone, I called a local pharmacy, and here's how the call went. Hello?
Hi.
I was wondering if your pharmacy carried naloxone?
Yes, we do.
Great, I'll be there in about 10 minutes. I'll see you soon.
Excuse me, but do you have a prescription?
I beg your pardon?
Do you have a prescription to purchase naloxone?
I do not. I didn't know you required one.
Well, technically you can purchase naloxone without a prescription at some pharmacies that have what's called a standing order. But unfortunately, you cannot do that here unless you have a prescription.
What exactly is a standing order?
Sorry, I've got a customer waiting for a refill. Good luck.
That was rude. So it turns out a standing order is a sort of binding agreement between a prescriber, aka the physician, and a pharmacy to enable purchase of a drug, naloxone in this case, without a prescription. The current law states that a pharmacist may dispense an opioid antidote to a patient regardless of whether the patient holds an individual prescription for the opioid antidote pursuant to a standing order issued by a prescriber. Okay, so I thought, I just got unlucky. I happened to call the one pharmacy in New Brunswick that didn't have a standing order. But in order to prevent this from happening to somebody else who might be calling because they actually need naloxone, it might be worth the time to compile a list of all the pharmacies that actually have a standing order. And a good place to start would be none other than our home, Middlesex County, which, by the way, ranks 4th in the state when it comes to the number of heroin-related overdoses that it experiences on a year-to-year basis. And so, with the help of 15 incredible medical students, many of whom are here today, we got to task and we identified 171 pharmacies in Middlesex County. It didn't take long before we realized how flabbergasted we were by the results. Out of 151 pharmacies, 110 pharmacies in Middlesex County did not have a standing order. Allow me to repeat that because I saw someone eating pasta while I was stating that. Out of 151 pharmacies, 110 pharmacies, roughly 73% of pharmacies, did not have a standing order. To add to our shock, a lot of these pharmacies also had no shelf supply of naloxone. What this means is, on the off chance that you actually did possess a prescription to naloxone, there was a very high likelihood that your local pharmacy in Middlesex County would fail you and you wouldn't be able to purchase naloxone. To put that into numbers, only a mere 34 out of 151 pharmacies in our county had shelf supply of intranasal naloxone. So let's quickly recap. Opioid overdoses are occurring at an unprecedentedly high rate. There's a life-saving drug currently available. There are legal measures put into place to enhance access to said drug. But for some reason, in the vast majority of the pharmacies in the county that experiences roughly 10% of the state's opioid overdoses, there's limited access to naloxone, the single opioid overdose antidote. How the heck does that make any sense? Ugh. And to accentuate that point, we decided to show this on a map. I bet you didn't see that coming. This is an aerial view of Middlesex County in the year 2017. The green pins represent all the pharmacies that did have a standing order. The red and yellow pins represent the pharmacies that didn't. Now, it doesn't take meticulous surveying to come to the same conclusion that we did, that there still existed a huge barrier to naloxone access. While identifying all the pharmacies that did have a standing order, which were few and far between, we inadvertently identified several regional deficits to naloxone access. As you might recall, as was the case for Dr. Snow's map, which presented one target, our map presents many. But similarly, both maps present that unique vantage point from which we can address this problem. In the case of Dr. Snow's map, it was to get rid of that single water pump. In our case, it's to recolor this map. And so that's what we've been doing for the last couple of months. Fortunately, since we started this project, we've been fortunate enough to receive additional help from our friends in Trenton, who have since then passed an addendum to the aforementioned law that now enables issuance of a standing order by the state health commissioner, essentially bypassing the need of a physician's signature. And now, I'm proud to show that this is what the map looks like today. Just kidding, that's pretty scary. We did make some progress, so let me try that again. Here's what the map looks like today. Now, looking at this map, I wish I could tell everybody here that we could just sit back and watch the opioid epidemic fade. But that couldn't be farther from the truth, because merely identifying pharmacies that have a standing order or shelf supply of naloxone means nothing if this information is not conveyed to those who can actually benefit from it. And that's why every single person here tonight has a stake in this. We need your help to raise the public's awareness about naloxone and where it can be obtained. And it doesn't stop there, because just identifying naloxone access points means nothing if prices remain unaffordably high. Therefore, we need to ask you to push our state legislators to continue pressuring drug companies to lower prices and for insurance companies to more generously cover costs. Only then, I believe that we can actually say we've improved access to naloxone. And what if we do achieve all of these things? Well, don't forget that this would only be to our county, our home, where we've identified just 150 or so pharmacies. And we can't be okay with that, especially when we are cognizant of the fact that this epidemic affects other parts of our state, such as Ocean County and Camden County, which arguably are suffering from this crisis to a worse degree. So we do need to ramp up our efforts, and that is the goal for the imminent future for our team. Earlier in this talk, I posed the question of whether a map could address an epidemic. Based on what I just said, I don't think a map will be sufficient alone. However, the information that could be gleaned from a map like this may be just the information that we need to at least start reversing the endlessly rising death toll due to opioid overdoses. And that's because I am absolutely certain that there are still several thousands, if not millions of people who require naloxone, but they're just out of its reach. So until naloxone is as widely available as our EpiPens, our nicotine patches, or our inhalers, we will continue to draw this map while simultaneously recoloring it. Now, in conclusion, I'd like to show you all a map. Now, I'm absolutely certain that nobody here will recognize this map, and I'm even more confident that no one will know who made this map. And that's because this is actually just a vision of what we believe can be achieved in the nascent future. However, it can only be achieved with all of your help. And so to that, I'd like to close by saying, come and help us make this map together. Thank you very much.